Good morning, everyone. Welcome to Pediatric Grand Rounds. Today we are fortunate to have Ms. Brooke Norton here to educate us all on maybe something we're not so aware of or being traditionally taught, ableism in medicine. Ms. Norton has a BA in English from Virginia Tech and psychology from Virginia Tech as well. She completed a master's in education in secondary English education from Virginia Tech and taught at Franklin County High School from 2014 to 2018. Subsequently, she became a full-time mom, caregiver, and disability advocate, and has been a volunteer at Carilion Clinic, actively involved in many aspects of care that she's going to educate us on. Please join me in welcoming Ms. Brooke Norton.
Hi, I'm Brooke. This will be pretty casual because I don't know how to be a professional anymore. There we go. I have no disclosures. That's me. That's our family. Evan is over here in the corner. You already heard all of that stuff. One thing I will note about my any image that I put in the slides, I have an image description rather than a caption underneath. That's one way that you can make presentations, your social media, whatever it might be, more accessible. Having image descriptions is important for those who use screen readers as they're using computers and such. So it's, pretty basic, a photo of a white couple holding their toddler son. They sit on a gravel road surrounded by tall grass. So that's like not super descriptive, and you can be more descriptive, like using like alt text in your slideshows and stuff like that. But that's a really simple way to start the work of anti-ableism in your personal life. Evan agrees. So Evan, my cutie boy over there, he was born at 34 weeks and 6 days. He spent 87 days in the NICU. He was pretty tiny for an almost 35-weeker. He had IUGR due to me and him and pregnancy just being the unpredictable, wonderful thing it is. When he was in the NICU, feeding and breathing were his biggest hurdles. He now uses a GJ tube, and he is exclusively J-fed. He had a Nissen fundoplication done while he was in the NICU. And we knew genetic things were happening, but we didn't know what until he was almost 2, is when we got his official diagnosis from Johns Hopkins of a mutation in the RPL10 gene. It is incredibly rare. There are approximately less than 7 cases in the whole world, so less than 1 in a billion. So there's very little research. The research that's done on the RPL10 gene you can find mostly in lionfish, which does not help us. So if anybody's looking for a research project, you should do that. He also has hypophosphatasia, which is caused by a mutation in the ALPL1 gene. I have it as well. So I actually learned a lot about myself after Evan was born, just through all of the testing that we did for him. My life started to make more sense because I realized that I had disabilities that I didn't know about. So since becoming a mom, and this is going to be true for all of your chronic patients, all of their moms or dads or caregivers, whoever watches them, they are not just a parent, they are a nurse, a therapist of all the genres. They are appointment secretaries, insurance denial experts, DME supplier relations specialists, medical researchers, advocates, educators, mentors, lifelong learners in recognizing and confronting ableism, which I'm hoping that we all will be by the end of today. And I became a formally diagnosed disabled person throughout all of that learning, that I not only had the hypophosphatasia that we discussed, but I also have arthritis and postpartum anxiety, complex PTSD, and ADHD, which is super fun. So I am speaking to you from a place of not just a mom, but as a person who's experienced ableism and wrestles with internalized ableism as well. So let's talk a little bit about what ableism is. I'm sure you've heard this word before, but you probably have not taken a deep dive into what that means and how that affects you, how that affects your patients. So simply put, ableism is just discrimination and social prejudice against those with disabilities. It classifies disabled people as less than and includes harmful stereotypes, language, and attitudes towards disabled individuals. So when we look at our patients, you want to think about, am I seeing this patient as less than my able-bodied normal, which is not a good thing to say, patients? Am I treating them the same way that I would treat an able-bodied patient? And there's just a lot that you can unpack there. So let's start. So before we get too far into now, it's important to know the disability history of our country. Throughout the 1700s to the early 1900s, a lot of, that's kind of like what we think about as like the archaic era of how we treated those with disabilities, but we're really not far off from that today. So there was a huge intersectionality between racism and disability, because in America, African Americans were considered disabled simply because they were not white. And so they were treated as such. It was seen as a defect in humanity. There was a ton of medical experimentation and torture, like our lovely father of gynecology. You know about these things, so we don't need to go into that. Institutionalization, abandonment, eugenics, and neglect. In 1945, we saw some of the first actual legislation to protect those with disabilities. Are you squirrely? So in 1945, the National Employee the Handicap Week was signed. And that really, as great as it is, the only reason that happened was because soldiers were coming back from World War I and World War II with complex PTSD, injuries from the war, and only then was something done on a national level for those with disabilities. So it sends the message that you have to sacrifice for your country, or you have to have been productive in order to have these protections. Does that make sense? So in the 50s and 60s, there were a lot of grassroots organizations pushing for a barrier-free society. There were Social Security amendments to provide aid for disability. Brown versus the board greatly affected disabled students. And then Medicaid and Medicare were established, and then we had the civil rights and disability rights movements kind of working together. In 1973, the Rehabilitation Act was signed, but it wasn't even entirely enacted until there had to be a sit-in that lasted almost a month. So disabled people sat in the Capitol. And Judy Heumann was one of the pioneers of the disability rights movements. She is still actively fighting for disability rights today. And according to Kitty Cohn, who was, this was the first time that disability really was looked at as an issue of civil rights rather than an issue of charity and rehabilitation at best or pity at worst. And I think that's where we're still stuck in our country and especially in medicine. The way that we treat disabled children especially is charity or pity. And both of those things are very not good. Yes, the charity model of disability provides services or whatever it might be, finances for people with disabilities, but it's coming out of a place of, oh, look at me, I'm so good because I'm helping the disabled. And it's not seeing the disabled person as fully human and fully, really just fully a person. So in '74, the last of the ugly laws were eliminated in America. And if you don't know what the ugly laws were, it was literally laws that said that disabled people were not to be seen in public. So if we're looking at where we are as a country, that was in '74. So yeah, still a long way to go. In '75, the Education of All Handicapped Children Act, which was renamed in 1990 to the Individuals with Disabilities Education Act, IDEA, which lots of your patients' families know a lot about because that is what gives them their rights in the schools. That was enacted, and then in 1990, we have the ADA, which we all know lots about, but it really barely scratches the surface, and we haven't seen a ton of progress since 1990 for the rights of those with disabilities. So while the ADA is great and it was a huge success for the disability community, there's still a long way to go because of the language in it can be very broad, and that can lead to loopholes. Just in the past year, there have been lawsuits that have almost gone all the way to the Supreme Court about discrimination of those with disabilities, and luckily, two of the really big ones were dropped, and that was basically going to take away all of the ADA rights, because like CVS, there was one with CVS, I can't remember who they were against, but basically the argument was, if it's not intentional discrimination, it doesn't count. And that is super dangerous and a very slippery slope. So when we look at ableism, we need to be aware that it's not just the intentional discrimination, because we all want to say that, like, oh, well, I'm not, I don't discriminate against my patients with disabilities. I don't see disabled people as less than, but when your actions and attitudes say otherwise, that's still ableism. So we can think that, like, it's the thing with like good intentions, like your impact is always going to be more important than the intent. Does that make sense? Yes? Okay. So looking at 2022, where we are as a country, this is just a few things. Sub-minimum wage and forced sterilization are still legal. Forced sterilization is legal in Virginia. So at the age of 14, disabled individuals can be sterilized with input from the caregiver and the doctor. And I'm sure y'all don't see a lot of that, but the fact that that is still legal is very concerning, because that is 100% eugenics. And, we don't want to do anything without informed consent, but informed consent for disabled individuals is a very loose term, because a lot of times conversations are had only with a caregiver and not had with the patient in mind, giving the patient agency. So we talked about broad language leading to lack of compliance. And really the biggest thing is that the onus remains on the disabled individuals and the disabled community as a whole for enforcing any of these ADA laws. Like, I have, just walking through Roanoke, the amount of ADA non-compliance that you see is just outrageous, because there's false beliefs about grandfather clauses for buildings that are not true. Often, you hear people be like, oh, well, it would just cost so much to make these renovations. And the only way that those are going to be enforced is through lawsuits. And I don't know a single disabled individual, like personally, that would have the money or the time or the energy to hire a lawyer and actually follow through with a lawsuit. And that's why these things don't happen. Forced poverty of the disabled community is making it so that they can't actually fight for themselves without the charity of others. And that is so dehumanizing. Looking at the COVID-19 pandemic, that continues to affect the disability community at disproportionate rates. Disabled individuals, it was the #1 cause of death in the past 3 years, has been COVID-19. Medical rationing that we saw throughout the pandemic, that disproportionately affects disabled people. At the beginning of the pandemic, I was very aware that if it came down to a healthy, neurotypical, non-disabled child getting a ventilator versus Evan would not win that fight, because his life is deemed less worthy than the abled individual. So we have a long way to go. Looking at COVID-19 as well, we have, y'all have seen it now, the lack of masking, the lack of care for just people's community as a whole. We have a very long way to go. Even the CDC, they're like, epidemiologists and virologists and public health experts were fighting against a lot of their more recent policies, because everything became more lax due to public pressure and capitalism rather than the actual health and well-being of Americans. And we have, right now there are two bills sitting in Congress that are making no progress, that would do a lot for the disability community. So we have the SSDI Restoration Act of 2021 and the Air Carrier Access Amendments Act. Those would actually give disabled individuals a little more, not a lot, but a little more basic rights and agency in our country. So as of right now, disabled individuals cannot hold more than $2,000 in assets without losing their disability benefits. There are waivers and stuff like that you can get, like Evan is on a waiver, but those waivers are very hard to navigate, they're hard to get, and the system is kind of built for it to be incredibly difficult. And I've spent way too much time trying to figure out the system, and I still don't have it figured out. And I have the time and the education and the supports to figure this out. That is incredibly privileged, and I'm very aware of it. So I'm always thinking about, the single mom who has more than one kid, I just have the one, who is working multiple jobs to just make ends meet. They don't have the time to navigate a system that was designed to exclude and pretty much just make it impossible to get benefits. So the Restoration Act would increase that assets level from 2,000 to 10,000, which is still peanuts, but it's progress in the right direction. And the Air Carrier Access Amendments Act is a really big one that I'm very passionate about, because we will never fly with Evan, because it is not safe to fly with Evan. Not, outside of COVID and all these things, the chances of his wheelchair being damaged, a wheelchair, not this one, because this one's gross and we hate it, but his new one that's coming sometime soon, wheelchairs cost tens of thousands of dollars. Evan's wheelchair will cost more than my car. And it is designed specifically for his body. Disabled people are not allowed to have their wheelchairs on the plane with them. The way they get on and off of a plane is very dehumanizing. Being carried in ways that are not safe by individuals that are not actually trained to assist disabled people. And on average, right now, 29 wheelchairs are damaged or destroyed. And I mean, damaged pretty much means destroyed, because it makes it unsafe for an individual to sit in it. 29 on average every day in America. A day. That's 29 people losing their freedom to move about in the world, losing their legs every day. And air travel is exempt from ADA standards. In many ways, it is exempt from ADA standards. And so that's just, another way that we still have a long way to go. As before Evan and before I learned things, I thought, oh, like, this is great, like, all these things. But we really have not made that much progress. And I think that as the medical professional community, you guys have a lot of power in how you will influence our country, the world, all the things. So there are two different types of ableism. So you have internalized ableism, and then you have external or systemic ableism. So internal is, the conscious or unconscious belief that those with disabilities are, just negative attitudes towards disability. Valuing yourself or individuals by their ability or productivity in society. Refusing to ask for help or accommodations when you need it. That's one I have personally struggled with a lot. Questioning your own diagnoses and whether you are, quote, disabled enough to fit into the disability community. Framing your comfort level as more important than a disabled person's comfort or dignity. Seeing access and accommodations as special treatment that makes things unfair. So external and systemic, using disability as a punchline, mocking disability, or using ableist slurs. So that's kind of where everybody thinks, oh, I'm not ableist because I don't do that, right? A lack of compliance with ADA standards, blocking or parking in accessible spots or access aisles, segregating or institutionalizing disabled individuals, unnecessary complexity of the social services system, which we talked about, sub-minimum wage, framing disability as either tragic or inspirational, no in between. Using the accessible bathroom stall when you don't need it. Asking invasive questions, staring or turning away from disabled individuals, and inspiration porn. And I think this is where we have a lot of ways to go as the health community, because we want to play, Coldplay's Fix You over videos of sad-looking disabled children to raise money for our causes, because that's, what's sad is that that's the only way people will care, to give money to like things like Children's Miracle Network, or in the UK they have something called Children in Need, And in listening to some of the disabled adults that I follow on social media, the way that they were negatively impacted growing up from organizations like that, where they're doing some good because they're obviously raising money for equipment and whatever it might be, but on the flip side, they're doing that at the expense of that child's dignity. So is it actually beneficial? You have to really, really think about that. Yeah. Okay, so just a quick 101 on ableist language. Instead of saying things like special needs, differently abled, handy capable, disability, or special abilities, say disabled. That is the most powerful, like this right here, that one is the most important thing that you can do as a medical professional. We have to erase special needs from our vocabularies. It's gross, it's ableist, it's yucky. Right up? Yeah. So just say disabled or person with a disability. Disability is not a negative thing that needs a euphemism. And we have to get away from that. Do not say wheelchair bound, say wheelchair user. Because I don't know a single person who uses a wheelchair that would see that as a terrible thing to be bound to. That is literally what gives them the freedom to move about in their world. Suffers from, and then insert diagnosis, change it to lives with, because saying suffers from immediately puts all this negativity upon that diagnosis that the individual may not see as negative at all. And it continues this idea that disability is tragic and terrible. Normal kids, do not say that, especially to your families of children with disabilities. You want to say neurotypical or typically developing kids. Nonverbal, this one is a little wishy-washy because in the deaf community, they do not love the non-speaking alternative because using ASL is speaking. But you could change that to just communicates with ASL, an AAC device, whatever it might be. Birth defect, don't say that. Congenital disability is what you would replace that with. Handicapped parking or bathroom needs to be accessible parking or bathroom because we want to erase handicapped. Low or high functioning, these are not replaceable. We need to just get rid of them because that is pigeonholing disabled individuals. And it is looking at, it's more or less categorizing certain disabled individuals as better than others. Does that make sense? Mm-hmm. And then mental retardation or mentally challenged. Obviously, the R word has been mostly erased, but even at Carilion, I have heard that word used as a medical diagnosis and as a joke. So we want to say intellectual or cognitive disability. All right, and I'm going to focus on special needs because this is the one that that pops up the most and that does the most harm. So the phrase in and of itself is not for disabled people. It was created as a euphemism just to make disability more palatable for non-disabled people that are uncomfortable with disability, which is silly because every single one of us could become disabled at any moment of any day, any time in our lives. It's the biggest minority group in the world, and it's one that anybody can enter at any time. So it frames disabled as bad or wrong or something so negative that we have to replace it. It's like this, it's like it's Voldemort, he who must not be named. But that's not for the disabled person. That's for non-disabled people's comfort, and that takes away some dignity. And here's why it's so bad. First off, it's inaccurate. Human needs are not special. Evan has a t-shirt that says, "My needs are human, they are not special." Every person has the need to be nourished or to eat in some way. The fact that Evan eats with a G-tube does not change that need. It's just how he receives that need. It implies that accommodating a disabled person's needs is optional when it's not. Accessibility is never optional, and it never should be considered optional, especially within the healthcare setting. So when we say, special needs, it's like, oh, like we're gonna do this special thing, and it makes it seem like it's this kind gesture that you're doing for the disabled person rather than a legal, basic human right. So we don't want to look at it as a special privilege. When we use the term special needs, it also does not cover us legally. So the legal term is disabled. So we need to be using that language especially if we're talking about rights and accommodations and discrimination. It's infantilizing, it's patronizing, and dehumanizing to the disabled person. It others those with disabilities rather than acknowledging that disability is a perfectly normal part of the human experience. 1 in 5 people in our country are disabled in some way, shape, or form. And like I said before, all of us could enter that category at any time. So in listening to the disabled community, it's clear that this terminology is insulting, and disabled activists are calling for its complete erasure from our vocabulary surrounding disability. And this is the term I hear the most frequently in healthcare settings with other parents of disabled children. We want to make it cute, and that's just weird. I do not appreciate when people refer to Evan as having special needs, because he does not. He has basic human needs, just like everybody else. And it puts, we don't talk about special needs adults quite as much, because we think that, oh, special needs kids are so cute and this, and that, but we forget that our disabled patients in pediatrics will become disabled adults. And we don't see, as a society, disabled adults. We really just don't even think about them a lot of the time. And we are gonna automatically put them in a category as child. Like when parents or just people in general refer to kids with Down syndrome or kids with cognitive disabilities as forever children. That's not true at all. And that immediately is going to put that child in a box where that child is not allowed to flourish and grow as they should. Because we're not going to give the supports they need and the tools they need to become adults that have independence. Does that make sense? I am not good at this clicker. Okay, so looking specifically at medical ableism. So these are some ways that it looks. This is not an exhaustive list. So the belief that in order to have a high quality of life, disability must be cured, fixed, or eliminated. The attitude of tragedy or curiosity towards disabled patients. This leads to pity and shame surrounding disability and in turn the child. The use of ableist language when discussing disability and diagnoses. Medical gaslighting and passing the buck. I don't know, have you guys seen the New York Times article that was circulating recently about, okay, so they did an anonymous study of healthcare providers, and through their questionnaire, they realized that, and it's sad that they're just realizing this when everyone in the disability community knows it. Medical providers do not want to treat patients with disabilities. They would rather have healthy, able-bodied patients because disabled patients require more care, they require more time, and that's not how the healthcare system was set up, right? We're set up for these 15-minute appointment windows for a well visit when, you know, like Dr. Henschel, she's great. She always schedules Evan so that there is enough time for her to just like not have lunch that day. So that she can spend the time that she needs to spend with him. So, you know, not having a complex care clinic is one way that we're gonna see lack of efficient and quality care for disabled children. And then the medical gaslighting, women face this at higher rates than men. And disabled individuals are going to face it at even higher rates. So not being believed that your symptom is really a symptom, having your concerns not heard. This idea that, oh, well, I have patients that are, you know, like a friend of mine who just left Carilion. She was under the care at Carilion, and she had been told repeatedly that her, like a specific medical issue wasn't a big deal because, you know, well, I have patients that are taking this medicine like this many times a day, like you're fine. Meanwhile, now she's on the brink of hospitalization for malnourishment. So that's, you know, we have to think about that. Like, are we actually listening to concerns and taking them seriously, whether we believe they're real or not, right? The first thing is that you should believe your patients. I know that like there's this idea that like, okay, you have to think like patients lie, but trust and then verify. And if the test results are not showing what they would show, dig deeper. Because sometimes normal test results happen when there's still something going wrong. And then passing the buck, so we've experienced this with Evan. I know tons of other families who've experienced this where you're passed off to a different specialist or a different practice or whatever because, oh, well, we just don't have what we need to support you. And sometimes that is logistical, like that is true. Like there's, you know, a specific type of CT that UVA could do that we can't do here. That made sense that we would go to UVA for that. But when there's no actual reason for it, don't pass your disabled patients along to somebody else. Step up, do the research, educate yourself to be able to give that patient what they deserve. Failure to consider safety and dignity of disabled individuals in medical settings. Scales, friends. Talk to whomever you need to talk to. There should be a way to get the weight of a child who uses a wheelchair without the caregiver having to hold them on the scale and then put them back in their chair and all of that. There are scales that do this. We should be putting our money towards things like that because dignity is non-negotiable. Toileting. I'm very excited, was thrilled, cried a little bit, knowing that when this building was built, there was a bathroom created with a large child/adult changing table over in Peds therapy. But this is the only building that I know of that has that anywhere. And we need to be pushing for that to be the standard in family restrooms that are large, that are fully ADA compliant, AKA I should not have to put my child on a dirty bathroom floor to change his diaper. That's a huge one. Germ and infection control. COVID has really opened my eyes to a lot of that. And then privacy. Are we talking about our disabled patients as these curiosities while sitting and having coffee? I know there's signs everywhere that's like, please just refrain from discussing patient information. But when we're looking at disabled patients, you know, like I get Evan is super rare, but are we looking at his rarity as a medical curiosity that is like fun to discuss? Or are we looking at it as a person who has a diagnosis that needs supports and needs to know how that diagnosis is going to impact his life? Infantilizing patients and talking about them rather than to them, it is rare that I experience an appointment where Evan is actually talked to by the caregiver or the medical provider. And that's sad. He's 4.5 years old. You need to talk to him. You need to tell him what you're going to do before you touch him. Lack of gynecologic care for disabled women and forced sterilization of disabled individuals. Lack of informed consent, so that goes to talk to the patient before you do anything to them. And then physical and sexual abuse at its worst. So some of our personal experiences, like I'm not just, you know, talking out of thin air. These are things that we've actually experienced in the last 4.5 years. The lovely head tilt and pitying look when discussing our kid's diagnosis, and being told that they're sorry for all we have to deal with in front of our child. You're such great parents, you're superheroes, and we get that just for doing the basic things any parent would do for their child. Taking them to the doctor when they need it. Making sure that they are fed and breathing and entertained and all, you know, all the things. You're so happy. So that indicates that that the child is a burden or less than. Like there's nothing inspirational about me loving my kid. Like I'm not gonna go up to Rachel and be like, man, you're so inspiring. You love those kids, although some days it might feel like that, right?
It should be inspiring.
But that's not something that you're gonna say to a parent of a neurotypical, typically developing child, so why are you saying that to your disabled parents? Does that make sense? This one, still. And this is a direct quote because these things burn in your brain as a parent. A CNA at a routine appointment. Oh, you wonder why these things happen to the little ones. I'm sorry, what? That's so rude. He's not dead. Like, why would you say that to someone? Yeah, you're like, I'm happy. Touching Evan or his mobility aids without saying anything to him first. Lack of pain management, just because Evan cannot say verbally out loud the way that you would communicate traditionally, my pain is a 10. We see this a lot, especially in the NICU, and there were studies that came out in the past couple of years that no parent of a NICU child is surprised by, that pain management in infants and preemies is not really something that's even considered necessary. Like, babies can feel pain. When a baby has a Nissen fundoplication and a G-tooth placement surgery at 2 months old, when they already have neuroirritability, why are we not giving them narcotics? Why are we not giving them adequate pain management? Why are we holding back? And I get we don't want to give narcotics. I'm very much, Evan will never get fentanyl again in his life. But Are we doing that because we are actually caring about the long-term well-being of the child? Or are we doing that because we think, oh, well, the baby's not going to remember it, so it doesn't matter? There are plenty of studies that tell us that the body does keep score. Kids that are in the NICU experience long-term traumatic responses to medicine. Even if they don't remember being in the NICU, their body does remember. And their body will remember that pain. Seeing my kid screaming, so upset, so in pain that he's shutting down visually, he is not wanting to be touched at all. It is heartbreaking and the most helpless feeling as a parent. We need to consider the comfort of patients who are disabled, who cannot speak, to say, my pain is a 10. Paying attention to body language, that is so important. And you know, parents know their kids. You guys always tell parents, oh, you're an expert on your kid. So when I'm telling you, hey, his pain is definitely a 10 out of 10, we need to do something about it, I'm not automatically not an expert on my child in that moment. We have to listen. Assumptions about our future family plans. This one's always fun. Having it be assumed, oh, well, you'll do genetics next time. For why? Why is that an assumption that I would do genetics next time? Am I going to abort my child that has what Evan has? Because that sends the message to Evan that I would have done that with him. And yes, there are families who, you know, would make that decision, but we're not going to assume that. Just like when parents receive a Down syndrome diagnosis early on, how many friends of mine have I heard were immediately offered termination? Yes, it's good that you make your patients aware of all of their options, but we can't automatically assume these things. If you wouldn't offer termination for a patient that came back as a boy rather than a girl, why are we offering that for Down syndrome? There's nothing wrong with Down syndrome. We should not be looking to eliminate that. Eugenics is not a good thing. Being told, oh, you want to adopt, that's great. Then you won't have to worry about all the risks. Referring to my child as something that I would be risking. Not good. What are the chances of you having another child that is, and then not even finishing the sentence, trailing off awkwardly and looking at Evan? I don't even have to explain why that one's so bad. Also, we've gotten, in talking about our adoption future potential plans, the assumption that, oh, so that you'll get a regular kid. We've gotten that from family, from friends, from medical professionals. And guess what? I don't want a regular kid. I would rather adopt a child from the NICU who has medical complexities. So assuming that these children are not desirable or worthy or seeing them as a potential risk, no thanks. Okay, yikes, I'm taking too long. Being told even though he's special needs, he can still manipulate you. Actual words from a human being, a nurse. Lack of appropriate mitigation strategies with COVID-19. This is making healthcare inaccessible and a hostile environment towards your patients with disabilities. I'm immunocompromised, Evan is immunocompromised, respiratory illness, Dr. Temez can tell you, respiratory illness would be very dangerous for Evan. Common cold has put him in the hospital more than once. and then still seeing people at Carilion not wearing their masks properly. And this is literally what I witnessed yesterday in this building. Not wearing masks properly, having their mask down over their chin while talking to a patient. Even when you have those little barriers, those little screens, it's not appropriate. It's A, against Carilion policies, and B, it sends the message that, oh, your comfort level is more important than my child's life. So following those policies appropriately is important. Not allowing disabled individuals and their caregivers to have a seat at the table when designing buildings, programs, or systems within Carilion Children's. When this building was being proposed, there was a panel of parents of kids with chronic illness, and hardly any of the things that we talked about being helpful and accessible were actually implemented. The Meadow was supposed to be a place for for families that have immunocompromised children to wait. That is what we were told. Now it's just kind of an offshoot of therapy waiting for kids that elope or have sensory needs, which is super important to have that. But, that really felt like a slap in the face when we had this large panel of parents saying, this is what's helpful, this is what we need, this is what's going to make doctor's appointments better and less anxiety provoking for our kids, and then not seeing those things follow through. So the power that you hold. Medicine has operated as the primary paradigm not only for the treatment of disabled bodies, but it has also shaped the way decision makers, legislators, families, and society in general think about and sense disability. So you guys, you hold most of the power when it comes to any kind of societal change with ableism. Your role in pediatrics. As a healthcare provider, your attitude towards disabilities directly impacts every single patient and their family. While it's important to provide supports, treatment, and education to the family about a diagnosis, your body language, your word choice, and your general attitude, we can sense when you're like, oh, I'm so sorry, even if you don't say it. That's critical to the trajectory of care that child will receive. If when giving the diagnosis, you treat it as this horrible, tragic, pitying thing, the parent is going to internalize that. And that's going to negatively impact that child in every single aspect of their life. Because if the people that are here to provide safety and care for the child have a negative view of a very important aspect of that child's identity, that child is not going to be adequately supported throughout their entire life. So don't approach with pity and apologies. It's damaging. You are not an expert on disability. Don't care how many letters are behind your name. If you are not disabled, you are not an expert on disability. And within the scope of disability, there are millions of experiences. So even with the same diagnosis, no two people are going to experience that disability the same way. So we need to think about individualized care. Standards kind of go out the window when you have a medically complex patient. You need to listen to and include your patient and their family as you make medical decisions and recommendations. Only if and when healthcare providers, educators, and students are routinely and meaningfully exposed to the perspectives of people with disabilities can they develop a consistent proficiency in diagnosing and treating ableism in their profession generally, as well as in their own practice. So don't just walk away from today and be like, oh, I listened to that thing, I got my points for whatever. Continue to listen to and seek out the opinions and listen to the experiences of disabled people. So providing adequate care, do your research and know the chart, know the relevant diagnoses. Don't walk into a room without knowing that patient, because I can tell you right now, I am very tired of repeating the same spiel about Evan to every provider I see. Read the chart. I get that you want to hear things from the parent perspective or from the patient's perspective, but within reason. I should not have to go through Evan's entire medical history every time we see a provider. Take time to listen and follow up with all patient and parent concerns. Take time to adequately explain diagnoses, treatments, tests, etc. to the family. Answer questions, and when you don't know something, just say that you don't know, and then go find the answer. Get to know your patients and families. What does the patient value and want out of life? We can't assume what people want out of life. Know the difference between doing things to your patients versus doing things for your patients. And this is one that, as a mom, I've had to really consider when saying yes to tests and treatments or saying no. Am I doing that to him or am I doing it for him? Complex patients require complex care, so communication between providers is critical to providing the care the disabled patients need. So further reading and resources, I think y'all have a copy of the PowerPoint, yeah. So these are some books that are really great for understanding disability. Demystifying Disability is a quick read, it is very practical, and I would start there. And more reading, if reading's not your thing, here are some videos that you can watch, some TED Talks given by disabled individuals about their experiences. Crip Camp is a great documentary on Netflix about the lead up to the ADA being passed. And yes, it says crip, and we don't want to say crippled, but a lot of disabled individuals have reclaimed these words. So my disabled friend Ryan can say, like, make a joke about being a cripple. I cannot do that to her. Does that make sense? So those are really good TED Talks. Let's take a quiz. Okay, choose the appropriate term you would use to refer to my son, Evan. So there's Evan in all of his adorable glory. What is the correct answer, friends? C. Yes. All right. Who or what should determine the health-related quality of life for a disabled patient? Is it A, the SF-36 and related standardized forms? Is it the medical provider? Is it the patient's family and caregivers? Or is it the patient? D, it is the patient. Oh yeah, Carly, you made an appearance. How can you combat medical ableism here at Carilion Clinic? A, seek out and listen to the experiences of adults and children with disabilities. B, do the internal work to reflect on your own personal biases, assumptions, and attitudes towards disability. C, work to eliminate ableist language in your vocabulary and correct it in others when you hear it. D, review policies and practices with disabled individuals' input. E, fight for accessibility beyond the bare minimum of the ADA in all spaces with the Carilion name. Or F, all of the above. F, all the above. Okay, does anyone have questions? I know that we have like no time left because I didn't take my Adderall this morning. Yes?
Thank you for your talk. I have two main questions. The first one is I wasn't aware there was a specially built bathroom for disabled kids here. So where is that? Because I would
It
like
is, so if you go down the hall straight all the way to pediatric therapy, it is on the, which is on the left at the end of the hall right before the doors to exit towards like facing Electric Road. The only downside to this bathroom is that you do have to go to the front desk of pediatric therapy and have to be let in because it's not, it's beyond the door where you have to scan.
So it's in therapies.
It's in therapies, yes. So that is the downside, is that it's not fully accessible because you can't just use it. You have to wait for whatever person is in front of you at the check-in desk, and do that. But progress is progress.
And then the second question is, I wasn't aware of the forced sterilization for disabled children. And is that, is that dependent upon the different level of disability, or is it mandatory for kids?
It is not mandatory, and I don't think that it is practiced heavily, but the fact that it is legal is the issue. So it typically happens in female patients, and it's a super complex issue, but it needs to be discussed with the patient. It can't be a decision made for that patient. So because of the overwhelming sexual abuse that female disabled individuals experience, not being able to get pregnant can be seen as a good thing. But the subject is very nuanced, and I think that, we need to look at better ways, like instead of treating the problem after the crime has been committed, we need to create spaces where patients are free from the possibility of sexual abuse. Because a lot of times that's happening in long-term care facilities. And staff members are the ones that are creating those problems. Yes?
So, tell me about weighing youngsters. We have the wheelchair scales here, but usually someone has to hold the child and stand on the scale, and then we have to weigh the person who's holding them. But then the kids get bigger. All my kids who are bigger never get weighed. What kind of scale is there that we could use?
I know they exist. I don't know specific brands or anything like that. But if they don't, if we don't have adequate ones, why is that not something that we're researching and developing as the medical community? Evan is like half my height, more than half my height at this point. He's still pretty little, but at some point, I'm not going to be able to lift him for him to get an adequate weight, and that immediately is going to negatively impact, because you don't have an adequate weight, then how are you adequately dosing that child for any medications they're receiving? So I will do some research for you, Dr. Chinez, and I will send you a MyChart message.
I'm proud of our wheelchair scales, but maybe not so.
Yeah.
All right, well, thank you so much.
Thank you, and anybody that has further questions or anything, you can email me, or even follow me on Instagram. I share a lot of disability rights information and perspectives, and that would be a great place for you to find other disabled individuals that you can follow. And this is Evan being so cute.
Oh, sweet boy.